Thank you for that long introduction. So, so for those of you that don't know me, I'm the director of the IBD program here at Capitol Health Center for Digestive Health. Today, I was asked to talk about Crohn's disease and ulcerative colitis, latest medical treatment options. I think this is a very appropriate talk. I gave this talk a few years ago. I don't know how many of you were at that talk before, but a lot has changed just in the past 2 to 3 years, just in the realm of medications for inflammatory bowel disease. So that's focus most of this talk on the medical treatments. We won't delve too much into dietary and surgical and other treatment options unless you guys have questions at the end. So I'm going to focus more on some of the medications with particular emphasis on what's new with existing medications, as well as having a discussion regarding all of the new medications that are available. I understand the audience is very broad here, ranging from patients, their healthcare providers, their friends, family, etc. So I'll try to keep this relevant to all of you. So, inflammatory bowel diseases are Crohn's disease and ulcerative colitis. There is an overlap of these called indeterminate colitis. Most patients present to a provider for symptoms of diarrhea, abdominal pain, and rectal bleeding. These are the hallmark symptoms. Of course, there are a lot of other GI symptoms like constipation, nausea, loss of appetite, rectal pain, and quite a few what we call extraintestinal manifestations like fever, fatigue, joint pains. But the hallmark symptoms are diarrhea, abdominal pain, and rectal bleeding, which usually brings someone to medical attention. So, to understand the medical treatments of inflammatory bowel diseases, it's important to understand some of the basic concepts that we have behind our treatment. So, number one, these diseases are chronic and often progressive diseases. They can lead to long-term complications. So, there's structural bowel damage that can occur. Many patients wind up getting hospitalized. Significant amount of patients wind up needing surgery. About 1/3 of patients with ulcerative colitis, for example, during their lifetime may need surgery to remove their colon. And 2/3 of patients with Crohn's disease may wind up needing some kind of surgery for their Crohn's disease. These are older statistics. Hopefully, these rates will start to go down as we discuss some of these new medications and more medications are used over time. But these are additional long-term complications. Many patients have various forms of disability. There's a significant decreased quality of life. And there are also some cancer risks over time with chronic inflammation. So the key here is optimal treatment, and starting treatment early in disease course is vitally important. Also, we need to understand that as of 2025, there still yet is not a cure for these diseases. There is no standard regimen, and treatments are individualized. So it may work for one person, or what you read about someone on a message board responding to a particular medication or dietary thing may work for one person, but may not work for the other person. The goals of treatment, I think, are common. We want to remove symptoms. That's the medical term that we call induction of remission. And we want to prevent recurrent flare-ups, what we call maintenance of remission. We want to help patients stay in control of their disease so that they can continue to pursue their normal activities of daily living. Treatment for IBD is multifactorial. Today's talk is mainly focused on medications. But as I mentioned earlier, surgery is definitely a treatment option for many patients. There are lots of dietary aspects to treatment. Emotional support is very important. This can be a very isolating disease, and certain lifestyle modifications can also help and play a role in treatment. So a few years ago, there was this international organization for IBD, which released something called the STRIDE guidelines, and it's a concept of treat to target. So this is a newer and proactive management strategy for IBD that most of us are implementing now. And this basically focuses on but basically focuses on achieving and maintaining specific objective treatment goals instead of just relying on symptoms. It involves early and aggressive intervention so that we can minimize inflammation. Inflammation is the enemy here. The chronic inflammation can start causing some of those long-term complications. So we're trying to, by intervening early, trying to change the disease course. We often have to do objective monitoring of markers of inflammation because we've come to understand that symptoms like diarrhea, and bleeding are not reliable to determine where we are in terms of how well a treatment is working. Requires regular re-evaluation of treatment targets. It's not good enough just to start you on one treatment and not see you for the next 4 or 5 years. We want to continually reevaluate so that we can modify treatments if target is not met. And we want to personalize care. It's important to get patients and healthcare providers on the same page. Short-term targets of treatment, generally within 6 weeks, is mainly focused on symptoms. So we want to get improvement of the hallmark symptoms of abdominal pain, bowel frequency, and rectal bleeding. Intermediate targets, which may take about 3 to 6 months, are improvement in biomarkers. C-reactive protein and stool calprotectin are generally the two biomarkers that we follow for most IBD patients. There are long-term treatment targets, usually take about 6 months or so. And mainly this is focused on endoscopic improvement or endoscopic healing. And the reason this has become a long-term target is we've come to understand that healing of the mucosa is associated with better long-term outcomes and preventing disease progression. Additional long-term targets are improving quality of life, absence of disability, absence of surgeries and hospitalizations, and for our pediatric patients to allow for normal growth. There are some aspirational targets. These are not yet part of the STRIDE guidelines. These may be come into play in the near future, where we're looking at things like histologic improvement. So what that means is basically when your doctor does a biopsy, for example, on your colonoscopy, even if your bowel looks normal, the pathologist should be able to read off a normal looking mucosa. And that is actually an aim that many newer medications are looking at. Some medications are achieving this. And again, if we can get complete healing, including histologic improvement, that may change the natural disease progression. And then we're also looking at potentially healing the entire intestinal wall. This is more relevant for Crohn's disease. This is a concept of what we call transmural healing, where when we do endoscopic tests, we're only looking at the lining of the intestinal wall. We can't see what's going on within the walls of the bowel, where there's also inflammation. And so as some of these imaging studies like MR or CT enterography and a newer modality called an intestinal ultrasound is very used more regularly, and people are more accustomed to using these for IBD, that these may serve as eventual targets of treatment as well. In addition, when talking about medications, we often need to define the severity of one's IBD. So, for example, for ulcerative colitis, and these are loose definitions, but for mild ulcerative colitis, this is generally accepted to be a patient that has up to 4 stools a day with occasional blood, but there's no systemic symptoms. Patients with moderate ulcerative colitis are having usually more than 4 bloody stools a day. They may become slightly anemic. They're probably having some abdominal discomfort. And then severe forms of ulcerative colitis, patients are having in excess of 6 stools a day. They're bleeding with almost every bowel movement. They're significantly anemic, requiring iron transfusions, blood transfusions, and they're starting to develop systemic symptoms like fever, weight loss, fast heart rate, excess fatigue. Full-minute disease, is more for patients that are usually in the hospital, constantly going to the bathroom, bleeding excessively, getting distended colon, risks of bowel perforation, which has a 50% mortality. For Crohn's disease, we have a concept of mild or low risk patients. These are patients that have minimal to no symptoms. They usually have normal CRPs, normal calprotectins. They generally present at an older diagnosis, meaning after the age of 30. The amount of inflammation seen on a colonoscopy is minimal, and the distribution of disease, for example, with Crohn's disease, this can involve any part of the GI tract from the mouth down to the rectum. So if you have multiple areas of bowel involvement, that considered to have a higher risk. If you have less involvement, it would be a milder or lower risk. Absence of complications. These are patients that have perianal complications like perianal fistulas, required a prior bowel resection, penetrating or strict drain disease. If you have that, that would be more in the moderate to high risk. Additionally, higher risk are patients under the age of 30, tobacco smoking history, very high inflammatory markers, extensive bowel involvement, presence of extraintestinal manifestations is considered a higher risk category for Crohn's, and patients that are steroid dependent. So in terms of classes of medical treatments, these are what we currently have available to us. So we have sulfasalazine and mesalamine. These are available in oral and topical forms. I won't be spending too much time on that group of medications. We unfortunately still have steroids in our medical treatment options. These are available in various formulations. There are immune modulators, which are being used less, but it's still available medical treatment options. These include mercaptopurine, azathioprine, methotrexate, tacrolimus, and cyclosporine. There's still a role for antibiotics for certain settings in IBD. So if someone has a complication like an abscess, a fistula, an overlying infection like C. diff, in patients with Crohn's disease who have had surgery and they've had a primary anastomosis where the surgeon has reconnected two segments of bowel back together, that area is very vulnerable to surgical and Crohn's recurrence. So antibiotics have a role there. And for those patients with ulcerative colitis who had to or chose to have a pouch surgery, sometimes patients develop a complication called pouchitis, and that requires antibiotics. But for the most part, most patients with moderate to severe disease are now being treated with a group of medications called biologics. There's three categories now, which we'll talk about. There's the anti-tumor necrosis factor or anti-TNF drugs, adhesion blockers, and the IL-23 inhibitors or interleukin-23 inhibitors. And we also now have oral therapies. They're called oral small molecules. And there's two general categories of these. They're called JAK inhibitors and S1P modulators or inhibitors. So sulfasalazine and mesalamine, just briefly, these drugs have been around a very long time, 30 to 50 years. These are just some of the more common names that you may be familiar with. These are available in oral and rectal forms. It should be emphasized here that we've come to understand that these drugs really are not effective in Crohn's disease at all. The rare exception is someone that has really mild Crohn's disease with mainly colonic involvement, or they have some indeterminate colitis features. In other words, they have some features that look like ulcerative colitis, because ulcerative colitis, especially mild forms of ulcerative colitis, mesalamine or 5-ASA is the mainstay of treatment. 5-ASA or mesalamine drugs, however, are not likely useful for more moderate to severe forms of ulcerative colitis. This class of drugs can be used both to induce and maintain remission. As I mentioned earlier, there are mainly oral forms of these medications, but there are topical forms of 5-ASA or mesalamine in the form of a mesalamine enema or mesalamine suppository. People usually know these by the names Rowassa enema and Canaza suppository. Most of our studies have shown that combining oral and rectal mesalamine is more effective than either route of administration alone, especially for patients that have more distal, proctitis or colitis. Generally speaking, with this class of medicines, compliance has been an issue for years, mainly because there's lots of pills that people have to take. It's a large pill burden. Inherently, many people forget to miss a dose or two or three, and pretty frequently. And studies with these medications, which there's not that many studies going on with these medications now, but traditionally in the past, there's been non-adherence to these medications, and studies have shown that many patients will relapse within 2 years pretty quickly. To improve compliance, some of these oral formulations can be taken once or twice a day instead of the 2, 3, 4 times a day that sometimes these medications require. I would say overall, this class of medicines by far has the safest safety profile. They do require monitoring of kidney function, which is usually a metabolic panel and or a urine analysis done once a year with your primary care or your gastroenterologist. Some patients have hypersensitivity reactions where they get inflammation of the lining of the lungs or the heart, a very rare side effect of this medication. And paradoxically, some patients get a worsening. So if your doctor starts you on a mesalamine and your colitis gets a lot worse, you may not be able to take that medication. Sulfasalazine has some additional side effects. I should just say basically 5-ASA or mesalamine is contained within the sulfasalazine molecule. So many years ago, they cut out the sulfa component, and the mesalamine component is believed to be the more active ingredient, but the sulfa component has some anti-inflammatory properties, but also is associated with some side effects like a decrease in white blood cell counts, sensitivity to the sun, rare but severe skin reaction called Stevens-Johnson syndrome, and headaches. Steroids, again, unfortunately, are still part of the conversation for medical treatments. They're only used for induction of remission. They're not used for long-term treatments. They're not for maintenance therapy because there's too many side effects in the long term. There are systemic steroids. Most people know this as prednisone, although there's also IV formulations of these medications. And generally, you don't want to be on these medicines longer than 4 to 8 weeks. There should be a tapering regimen. Um, these steroids are also available in topical forms like hydrocortisone enemas, suppositories, and a foam. The better steroid, if there are such a thing, is budesonide. This is rapidly metabolized by the liver after your first dose, so there's fewer corticosteroid-related side effects. This medication mainly works topically, and therefore is less effective than systemic steroids like prednisone. They're really only indicated for mild to moderate disease, and they're a little bit slower to have an effect. They may take up to 7 to 10 days. This is a common area of conflict that we run into with pharmacies. So there are two formulations of budesonide that can be used in setting of IBD. There's a budesonide EC, commonly known as Entecort. These come in capsules, so 3 mg each. Usually patients start at 3 capsules a day and then they taper down. This formulation is only approved for Crohn's disease. It is not approved for ulcerative colitis, and that's where a lot of times the pharmacy will dispense or the insurance will only cover this one and not the other one for ulcerative colitis. And the reason is this capsule is made in such a way that it's released in the end of the small bowel and works in the end of the small bowel and proximal colon. That is not where most patients with ulcerative colitis have disease. So this medicine really is not intended for use in ulcerative colitis, it's only for Crohn's disease. The other formulation is called budesonide with extended release technology or MMX technology, also commonly known as Ulceris. This comes as a tablet. It's a 9 mg tablet, so it's all 9 mg in one tablet, and it's formulated to work only in the colon. And there's also a rectal foam version of this called Ulceris or budesonide rectal foam. This is only really indicated for distal forms of ulcerative colitis. Immune modulators, I'm not going to talk too much about these. You'll rarely see these medications prescribed now as a primary or initial treatment. Usually the only patients that have on these medications now are those that have been on these for years, and or if they're taking an anti-TNF drug, which I'll explain in a little bit. But these are basically azathioprine, commonly known as Imuran, and azocin or 6-MP, also known as Purinthol or Purixan. This class of drugs was discovered in the 1950s. They were initially anti-cancer medications, but they were found to have immune suppressing properties, and therefore they are effective in many autoimmune diseases, including Crohn's and ulcerative colitis and various types of arthritis. And they're used for organ transplant patients uh, to prevent organ transplant failures. These are slow-acting drugs. They're not going to help you rapidly get better, so they're only really indicated for maintenance. They do have steroid-sparing properties, which is probably the most important thing, meaning they have similar effects as steroids without the steroid side effects. And the main role is using these medications in combination with anti-TNF drugs. Many patients with anti-TNF drugs develop antibodies, and this is one way we have of preventing antibodies from developing. I'm going to skip this part just for the sake of time, but I just want to point out at the very bottom, main concern with these medications is the malignancy risk. It's not a very high risk, but there's been some reports of a lymphoma that occur in young men, and any patient above the age of 50, there's slightly higher risks of lymphoma. There's non-melanoma skin cancers that happen with pretty increased frequency with these types of medications, and also genitourinary or urinary tract cancers. These are bladder and kidney cancers, for example, and prostate. Another group of immune modulators is methotrexate. Again, not used that much anymore. This was discovered back in the 1940s. I should say not used much in Crohn's and ulcerative colitis, but these were initially discovered in the 1940s as a cancer chemotherapy drug in very high doses. They found that in low doses, these drugs did have anti-inflammatory properties, and for this reason, they've been used for many years for autoimmune diseases like psoriasis, psoriatic arthritis, rheumatoid arthritis. I believe in the 1980s, they discovered that injectable forms of methotrexate in low doses were effective for Crohn's disease, both for induction and maintenance of remission. The oral form of this is not effective in Crohn's or ulcerative colitis. The main role of oral methotrexate is to prevent antibodies from being developing to some of the anti-TNF medications, and possibly for maintenance of treatment. I find that they often do this in pediatrics. Methotrexate really does not work well in ulcerative colitis, so it's mainly for Crohn's disease. It has steroid-sparing properties. And really, the only role that methotrexate has in my patients these days is when we're using it in combination with anti-TNF drugs to prevent antibodies, because they are not associated with lymphoma risk that the thiopurine drugs may sometimes be associated with. These are just some side effects of methotrexate. I believe you'll have these on the slide to review. So I'm going to skip this. And next, I want to talk about biologics. So biologics are quickly becoming the mainstay of treatment, and they have been now for the last 10 to 20 years for many forms of autoimmune diseases, not just ulcerative colitis and Crohn's. There are several classes of anti-TNF, several classes of biologics we have now. So I mentioned earlier anti-TNF agents. TNF stands for tumor necrosis factor alpha. So this was it is a pro-inflammatory cytokine that our body normally produces to fight off infections and cancer and any kind of inflammation. And it was discovered some 25 years ago that, maybe longer, the TNF was produced in excessive quantities in various autoimmune diseases, including it was found in very high levels in the bowel mucosa. So an antibody to TNF by neutralizing TNF was found to have significant anti-inflammatory properties for various autoimmune conditions. And again, these drugs have been around 20 plus years. Hard to believe, but they've been around a long time. These are the names of the anti-TNF drugs that we use for Crohn's and ulcerative colitis. Infliximab was the first one. It's more popularly known as Remicade. There are now lots of biosimilars of this. So it's important to know the generic name, infliximab. This was initially approved for Crohn's disease 27 years ago in 1998 and ulcerative colitis 20 years ago. And it's traditionally been given as an intravenous infusion starting at week 0, which is your first dose, week 2, and then week 6. And then if it works without side effects, the maintenance dose is every 8 weeks to start, although the frequency can be changed over time. The key thing with infliximab is it is a weight-based drug, so the dose can be adjusted depending on your weight and depending on your needs. The second anti-TNF that came on the market was more popularly known as Humira. The generic name is adalimumab because now there are quite a few biosimilars of adalimumab on the market. This drug was first approved back in 2007 for Crohn's and then 2012 for ulcerative colitis. And the main differentiating feature of this is more of a humanized protein, and it's available as a subcutaneous injection, so a more convenient dosing option for most patients. Adalimumab is a every 2-week dosing for maintenance. Then certolizumab is approved for Crohn's disease. It's also known as Cimzia. I don't think that's yet available in biosimilar. And that is a monthly injection for Crohn's, so a little bit more convenient than Humira. And golimumab or Simponi was approved for ulcerative colitis only in 2013, and that's also a monthly injection. So these anti-TNF drugs, for the most part, are approved for both Crohn's and UC. They're approved for both induction and maintenance of remission. Importantly, they can be used for adults, and they also have pediatric indications as young as age 6. So if you may not be familiar, we're seeing younger and younger patients getting diagnosed with these inflammatory bowel diseases. And for a long time, there was a vacuum in treatment options for younger kids that weren't responding to conventional treatments. But now these drugs can potentially be used as young as age 6. They are rapid acting, particularly infliximab. So sometimes in severe hospitalized patients, we have to give them a dose of infliximab, and sometimes it's a key difference between needing surgery and having rapid improvement in symptoms. They have steroid-sparing properties. These are features that most of the medications I'll be talking about have similar potential advantages or benefits. Though the anti-TNF drugs were not specifically assessed for mucosal healing in clinical trials, they've been around long enough that we clearly see that they do have the potential to heal the intestinal wall with all the benefits that has, as I outlined earlier. Anti-TNFs probably have, of all the medications I'll be talking about, at least they have the most data for potentially medically closing fistulizing Crohn's disease. So these are Crohn's patients that have a fistula between the bowel and the bladder or the vaginal area or the skin or bowel to bowel. So anti-TNF drugs potentially can close these medically. And as I mentioned earlier, they have a role in post-surgery prophylaxis for Crohn's patients. Side effects of these medications include allergic reactions, including infusion and or injection reactions, depending on the formulation. Most of these medications, including anti-TNFs, can be associated with increased risks of infections. They're usually minor infections like an upper respiratory infection. It's much less likely or much more rare to develop a major infection or an opportunistic infection, but they can happen. Tuberculosis and hepatitis B are very common infections worldwide. Most patients have dormant disease, but they can reactivate on anti-TNF medication. So we do screen everybody for hepatitis B and tuberculosis before starting treatment and periodically reassess while on treatment. Malignancy is a concern that many patients have, but again, these drugs have been around some 20 plus years. And so we have a long body of evidence. The main cancer that anti-TNF drugs are associated with, and it's not a very high risk, is skin cancer, in particular melanoma. The risk is only about 2 to 3 times higher than the average person. So it's not like it's a 10 times higher or 50 times higher risk, but it's there. So we do ask patients wear sunscreen, see a dermatologist every 1 to 2 years, this for skin prevention measures. Lymphoma is I believe, a black box warning on these medications, but this was basically from the drug that came out when these drugs first came out 20 years ago. We were often using them together with thiopurine drugs, and the thiopurine drugs are associated with a small but increased risk of lymphoma. And they discovered the combination of the thiopurine drug and anti-TNF drugs was leading in some young men to develop a rare but fatal form of lymphoma called hepatosplenic T-cell lymphoma. So because of that, we started using thiopurines less, but the patients that have just been on anti-TNF drug by itself, there does not seem to be increased risks of lymphoma or leukemia beyond the baseline risk that most patients with autoimmune disease have of any kind. They generally have higher risks of lymphoma and leukemia anyway, not a much higher risk, but how much added risk thiopurines add? Probably a little bit. Anti-TNFs, we don't have to see evidence that by themselves they increase risks of lymphoma. For those that have advanced heart disease or significant risk factors for advanced heart disease, some patients can develop heart failure. Blood counts, like a CBC, checking your white count, your hemoglobin, your platelets should be monitored annually, I would say, because some people can have a drop in their counts with anti-TNF medications. Demyelinating disorders are disorders that mimic multiple sclerosis or MS, drug-induced lupus reactions, and psoriatic skin lesions. These are rare side effects of TNF medications, but they can occur. These should be assessed at every office visit with your doctor. And the first sign of anything like this potentially developing needs to be investigated immediately. And if the final conclusion is there is a demyelinating disorder or drug-induced lupus or psoriatic type skin lesion that's attributed to the TNF generally should be discontinued, and these side effects tend to go away. With most anti-TNF medications, live vaccines, I should say that with all anti-TNF medications, live vaccines should be avoided. So our experience with anti-TNF medications, like I said, they've been around 20 somewhat years. They have a very good and long-term safety profile, and we understand the safety profile really well. About a third of patients don't benefit at all. I would say approximately half of patients will lose response over time, and that's because of the development of antibodies for most people, although sometimes there's a change in the disease mechanism for their IBD. So it's important with these medications to remain on your prescribed schedule. These medicines are given at a certain set frequency because if there's a long gap in treatment for whatever reason and there's no drug in your system, your immune system can generally start making some antibodies, and over time that can lead to things like infusion or injection site reactions, more side effects, and loss of response, which is difficult to absorb if the medicine's otherwise working really well for you. So what's new with anti-TNF medications? There are biosimilars of these medications. Over the past years, we've had something called therapeutic drug monitoring, where we can actually check a trough level of these drugs to see what the level is right before your dose and make appropriate changes in your dose or frequency to optimize outcomes, as well as to check for antibodies. And infliximab has been available as an infusion for 20 plus years, but I believe 2 years ago they approved the first injectable version of infliximab called Zinfentra. It's only for maintenance, so the way you would do this is if you choose to do this route of injection of infliximab, you still have to get 3 IV loading doses. And then 4 weeks after your last IV dose, you would start subcutaneous infliximab and then continue every 2 weeks. And if you're transitioning from IV infliximab, the way you start subcutaneous infliximab is instead of your next IV infusion, you do your first injection and then every 2 weeks thereafter. Adhesion blockers, there are two on the market. Tysabri, I'm not going to talk much about because we don't use this in Crohn's disease. I believe it's still around for multiple sclerosis. The reason we stopped using it is because there's a risk of a rare but fatal brain infection called progressive multifocal leukoencephalopathy. So several years later, another company was able to discover a similar molecule called vedolizumab or Entyvio that works through the same receptor pathway. This is not an anti-TNF medication. This is a medication that prevents the attachment of circulating immune cells from attaching to the gut wall so they can't get in. It's like changing the locks. So it's a gut-specific anti-inflammatory. Vedolizumab does not cross the blood-brain barrier, which is why it's not associated with progressive multifocal leukoencephalopathy. This was approved back in 2014 for both Crohn's and ulcerative colitis. It's traditionally been an IV infusion with a very similar infusion schedule to Remicade. Week 0, week 2, week 6, and then usually every 8 weeks, although it can be given every 4 weeks. And if there's no improvement by week 14, then the medicine probably should be stopped. This medicine is approved both for induction and maintenance of remission. I won't go too much into the statistics here. A lot of the statistics are readily available online on each of these respective companies' websites. And I've jotted down what I think was the most important findings here if you want to see the percentages. But key takeaways here is it's effective both for induction and maintenance for both ulcerative colitis and Crohn's. It can work as quickly as week 6. We start to see improvement in symptoms. I would say, in my anecdotal experience, it's a lot more effective for ulcerative colitis than it is for Crohn's disease, in particular, Crohn's disease of the small bowel, whereas Crohn's disease of the colon Entyvio works pretty well. Like most of these medications, it has the potential to heal the mucosa and to achieve steroid-free remission. There are now over 215,000 patients in the United States alone that have been prescribed this medication. It has a really good safety profile and continues to show a good safety profile after 10 plus years. The risks of this medication are things like infusion reactions or allergic reactions. Because it's a gut-specific immune suppressant, you don't tend to see other infections outside the GI tract, but there may be increased tendency towards bowel infections, or if you were to get a stomach bug or C. diff infection or other stomach bug, you might have a more protracted or longer course than someone else that also developed the same infection. Some patients can develop antibodies to vedolizumab, but it's less likely than anti-TNF medications. Only a small percentage of patients develop antibodies. There are ways to check drug levels and antibodies, but we rarely have to do this. There is no significant association with progressive multifocal leukoencephalopathy, which was an issue with Tysabri, but you will see this on the product literature. There was one patient in the clinical trial that did develop PML on Entyvio, but this was a patient that also had advanced AIDS, and PML is also an infection that happens in AIDS patients. So it was not believed to be a side effect of the medication. It can sometimes cause abnormal liver enzymes. And I would say very important is vedolizumab is not really associated with significant malignancy. So this is often our go-to drug in patients that have a history of various cancers or are concerned about history of cancer. The most common side effects with this category of medicine were disease exacerbations, nasopharyngitis. That's like a runny nose, watery eyes, and some patients get joint pains on the medication. Several years ago, we had our first head-to-head study. So we now had Entyvio. We also had Humira, which at the time was the #1 prescribed medication for Crohn's and ulcerative colitis. So this drug, Entyvio came out. Which one should we pick first? So we had our first major head-to-head study between these two medications called the Varsity study, where they took patients with moderate to severe ulcerative colitis and gave them either Entyvio at standard induction and maintenance dosing or Humira or a placebo. And the outcome of the study suggested that more patients on Entyvio were able to achieve clinical remission versus Humira by week 52, and more patients on Entyvio had endoscopic improvement compared to Humira. So Entyvio basically could be considered a first-line medication for moderate to severe ulcerative colitis. So what's new with this medication, in December 2023, they did approve an injectable version of this medication. So it's a 108 milligram dose. And the way you use this medication is if you're going to start with it, you still have to get the first 2 doses via IV infusion at week 0 and week 2. And then at week 6, instead of getting, excuse me, an IV infusion, you start the subcutaneous injection and then proceed every 2 weeks. Or if you've already been on Entyvio IV infusions for years and you want to transition to the sub-Q, instead of your next IV infusion, you start your first sub-Q and then every 2 weeks. I would say the biggest hurdle with this medication is getting your specialty pharmacy to dispense it or your insurance company to approve it. All right. So next, sorry about the typo there, but I'll be talking about interleukin 12-23 or interleukin 23 specific inhibitors. This is a hot area of IBD management. So ustekinumab or Stelara was the first one that was approved for ulcerative colitis in 2006, sorry, Crohn's disease in 2016, and ulcerative colitis in 2019. Though this drug has been around since 2009 for plaque psoriasis and also has an indication for psoriatic arthritis. At the time this molecule was discovered, it was thought that blocking interleukin 12 and 23 was relevant to autoimmune diseases. We've now come to understand that blocking IL-23 is more specific. So that's why when I talk about the newer formulations of these medications, they're probably a little bit more effective. But Stelara is indicated for treatment of adult patients. So it doesn't yet have a pediatric indication, but for adult patients with moderate to severely active Crohn's or ulcerative colitis who have failed or were intolerant to conventional treatments like immune modulators or steroids and have not yet been on a TNF blocker, or failed or were intolerant to one or more TNF blockers. The very first dose of this medication is an IV, weight-based IV induction dose. And then 8 weeks later, you start your first injection. It's a pre-filled syringe device. It's 90 milligrams every 8 weeks. So these are some of the outcomes with this medication. For Crohn's disease, more patients had clinical response versus placebo, both in patients that were previously on an anti-TNF drug as well as those that were not. They did find that abdominal pain and stool frequency improved as quickly as 2 weeks into treatment. So that's an important thing to note. Many patients, when they're not doing well and we're going to start medication like this, they want to know how quickly they're going to get better. And most patients know with systemic steroids, they'll get better within days. So the answer for Stelara is most patients get better by 2 weeks if the drug works. And the studies also showed for Crohn's disease, remission at 1 year was achieved in 53% of patients versus a third of patients in placebo. For ulcerative colitis, this drug also had promising outcomes and more favorable outcomes compared to placebo when it came to clinical response and clinical remission. And it continued to show durable response at 1 year. More patients receiving Stelara achieved clinical remission at 1 year compared to placebo. In general, with most of these medications, and the same held true for Stelara, patients that had not yet been on another biologic or anti-TNF fared better than those that had already been on an anti-TNF and failed that. They did find that majority of patients, 96% of patients that achieved remission were in steroid-free remission. Stelara was also the first and only FDA-approved biologic treatment in ulcerative colitis that achieved this relatively new endpoint called histoendoscopic mucosal improvement, both at week 8 and week 52, which, as I mentioned earlier, is probably going to become one of the targets of IBD treatment if we can get histologic and endoscopic healing. So this drug in general is proven to be quite safe. There are infusion reactions that can occur with that first IV infusion and or injection site reactions with each maintenance dose. Some of the more common side effects are, again, nasopharyngitis. You'll see this is a very common theme with these medications, upper respiratory infections, headache, and fatigue. And then infections include bacterial, fungal, and viral infections. Tuberculosis needs to be screened for and assessed during treatment. One patient in the clinical trial for Crohn's disease developed headaches, seizures, confusion, and visual disturbances. This is called posterior reversible encephalopathy syndrome. That patient did recover, but you will see it on the product label. Non-infectious pneumonias. There really isn't much of a malignancy signal, maybe non-melanoma skin cancers with ustekinumab. Also, all live vaccines should be avoided. We do have an antibody and drug level test for this medication, not often needed because the development of antibodies to this drug is rare. So what's new with Stelara? As of January 2025, your insurance carrier is probably not going to dispense Stelara to you anymore. They will dispense one of the ustekinumab biosimilars. These are just some of the names I think that are all commercially available. I think most of these are the ones that are commercially available in the United States. The biosimilars are interchangeable for the most part. They're non-inferior to the original product. They have the same risk-benefit profile, and it's been a pretty smooth transition for most of our patients in terms of no loss of response or new side effects when switching from brand Stelara to one of the biosimilars. IL-23 specific inhibitors. These are, if you watch enough TV or read through magazines, these are the medicines that are really hitting the advertising realm. So risankizumab, Skyrizi, guselkumab, Tremfya, and Mirikizumab or Omvo. These are all IL-23 specific inhibitors. They have a little bit better dosing flexibility than Stelara, and they're probably dosed better. They have basically very similar to Stelara in terms of efficacy, similar risk-benefit profile. Skyrizi was approved in 2022 for Crohn's disease, and then ulcerative colitis in 2024. It's also used for plaque psoriasis and psoriatic arthritis. Induction dosing is via IV infusion. So for Crohn's disease, you get 3 infusions at week 0, week 4, week 8. And it's a 600 milligram dose, whereas for ulcerative colitis, it's the same schedule, but a 1200 milligram dose. Maintenance dosing is via an injection every 8 weeks, but it starts at week 12. There's 2 dosing options available. There's a 360 or a 180 milligram dose. It's recommended to use the lowest effective dose. Skyrizi is usually administered through this device called an on-body injector device. It's pretty small, as the picture shows here. You don't actually see the needle. There's a little cartridge that you put the medicine vial into, and then you put a little adhesive onto your skin in the lower abdomen or thigh. You press a button there, and then it injects the medicine over a few minutes. 93% of patients find that it's very easy or very easy to use. I left a link there on the Skyrizi's website to see. It's a really good video to see how to inject the medication. So just for the sake of time, I'm going to skip by some of the data here, but there are 2 induction studies for Skyrizi, and they use patients that were previously on anti-TNF or other advanced therapies like Entyvio or Stelara, and then those patients that had not yet been exposed to these medications. And they found that more patients receiving Skyrizi compared to placebo achieved endoscopic response, clinical remission, and endoscopic remission compared to placebo. And then extending out to week 52, both maintenance doses of Skyrizi 180 and 360 milligrams also fared better when it came down to endoscopic response, clinical remission, and endoscopic remission compared to placebo. We also now have a head-to-head study comparing Skyrizi to Stelara for Crohn's disease. It's called a sequence study. They took all patients with moderate to severe Crohn's that did not respond to an anti-TNF drug, and they gave them either Stelara or Skyrizi at each individual drug's standard induction and maintenance dosing. They used the 360 milligram for Skyrizi for maintenance up to week 48. And they found that this drug at week 24 was just as effective or non-inferior to Stelara by week 24 when it came to clinical remission. And this drug showed higher rates of endoscopic remission. That's a complete healing of the bowel at week 48 for Skyrizi compared to Stelara. All right, So Skyrizi, as mentioned, is also approved for ulcerative colitis. The induction dose is higher. Similar positive outcomes at week 12 for patients on Skyrizi versus placebo when it came to clinical remission. And then this extended out to week 52. Patients receiving both Skyrizi maintenance doses of 360 or 180 milligrams had higher rates than placebo also for things like endoscopic improvement or complete healing of the bowel or endoscopic remission, more rates of steroid-free remission. In fact, over 97% of patients were steroid-free at the end of the clinical trial. It also showed histo-endoscopic mucosal improvement and resolution of bowel urgency. So Skyrizi usually works as quickly as week 4 in terms of symptom improvement, and it is again effective despite prior biologic exposure. In terms of safety, there's been now over 9 years of clinical trial experience across the 4 approved indications. For Crohn's disease in the trial, there was one patient that had a severe rash and severe elevation of their liver transaminases. Final conclusion was that was a drug-induced hepatitis. And so that's now on their product label. So this happened during the IV induction, and it's only happened in the Crohn's disease trial in only one patient. But most patients, well, every patient that's going to be starting Skyrizi, I would check liver enzymes before we start treatment and right after each of the 3 IV infusions, and would ask the patient to notify us right away if they have had a rash. I don't believe this has been reproduced in any other patient ever that's been treated with Skyrizi for Crohn's, but because it happened in the clinical trial, we have to be aware about it and monitor appropriately. Hypersensitivity reactions can occur. Infections do occur with these types of medications, including tuberculosis. Again, live vaccines should generally be avoided. The most common side effects that were seen for Skyrizi in clinical trials during the IV induction included upper respiratory infections, headaches, and joint pains. And then during the injection treatments included joint pains, abdominal pain, injection site reactions, anemia, pyrexia, which is subjective fever, back pain, again, achy joints and urinary tract infections. And for ulcerative colitis during the IV induction, the most common side effect seen was joint pains, and during maintenance injections, joint pains, subjective fever, injection site reactions, and rash. Guselkumab Tremfya is now approved both for Crohn's disease and ulcerative colitis. It also again has indications for plaque psoriasis and psoriatic arthritis. The induction dosing is like Skyrizi. It's 3 IV infusions a month apart, but one thing that sets this apart is it now has approval for subcutaneous induction dosing for both ulcerative colitis and Crohn's. So this is the only IL-23 specific inhibitor that can be given via induction for IV or sub-Q route. Dosing is the same both for Crohn's and UC. I have the dose written out there at week 0, week 4, week 8. And then maintenance dosing, there's one of 2 doses. There's a 100 milligram dose every 8 weeks, which starts at week 16, so 8 weeks after your 3rd infusion. That dose is already on the market for plaque psoriasis and psoriatic arthritis. And then there's the dose that's only approved for Crohn's and UC, and that's the 200 milligram every 4-week dose. And this starts at week 12, which is 4 weeks after the 3rd infusion. So usually we want to use the lowest effective dose. These are the 3 injection devices. You have a pen, you have a patient injector device there, and a syringe. I'm going to, for the sake of time, pass by some of the efficacy data, but IV induction studies did show for in Crohn's disease for Tremfya that it was not only more effective than placebo, but they also had a Stelara treatment arm here. So it showed that Tremfya for Crohn's patients did better than Stelara. There are 2 IV induction dosing regimens here. There was more rates of clinical remission with Tremfya through IV induction than placebo, and endoscopic response with Tremfya versus placebo. And at week 48, more patients receiving either of the Tremfya maintenance injection dosing were more likely to achieve deep remission compared to Stelara. So many times I get asked which of these drugs should I pick, Stelara or Tremfya. These are the data that we usually go with. There's clinical trial data that suggests one may be better than the other. This is the subcutaneous data for Crohn's. As I mentioned, there's subcutaneous induction dosing, and again, you can see high rates of clinical remission and endoscopic response with subcutaneous induction dosing compared to placebo, and this extended out to week 48. For ulcerative colitis, Tremfya also is available for IV induction dosing and subcutaneous dosing. And as you would expect, the clinical trials did show more efficacy with Tremfya in either IV or subcu induction dosing when it came to clinical remission, endoscopic response, and endoscopic remission than placebo. There's also long-term data now with Tremfya, where a majority of patients who were in a symptomatic remission or endoscopic improvement after 1 year of treatment continue to show similar results at 2 years. Safety is very similar to Skyrizi because it works through the same receptor pathway. So I'm not going to repeat some of these. They're very similar to what I talked about with Skyrizi. Tremfya has been around a little bit longer though, so there's a little bit longer body of evidence. And though liver enzymes should be monitored, there really isn't anything on the product label that necessarily requires you to check liver enzymes. Again, Tremfya can work as quickly as week 4 and can be effective for patients that have previously been on a biologic. Mirikizumab or OMBO is now approved both for ulcerative colitis and Crohn's. On the right there is the pen device. It's also available as a syringe. Again, it can be used for both bio-naive patients, those that have never been on advanced therapies, and those that have been on it before. For Crohn's disease, the loading dose is a 900 milligram IV infusion at weeks 0, 4, and 8, and then a 300 milligram maintenance dose every 4 weeks. That starts at week 12, or 4 weeks after your last infusion. For ulcerative colitis, the IV induction dosing is lower. It's 300 milligrams IV at weeks 0, 4, and 8. And the maintenance dose is also lower, 200 milligrams every 4 weeks, but it starts at week 12. So the studies for Crohn's disease show that there was a decrease in abdominal pain as early as week 6, stool frequency at week 12, and fatigue by week 12. So by the third dose, you had improvement in symptoms for Crohn's disease. I'm going to leave some of the data here for you guys to review. But overall, it does show long-term outcomes out to 2 years. Also, there was some component here in the studies that showed more patients that failed other biologics, 49%, achieved clinical remission with OMBO compared to those patients with Stelara, again, suggesting that it may have better outcomes than Stelara. They also measured bowel urgency, a very important symptom that patients with IBD have, and it showed that patients receiving OMBO did seem to have better improvement in bowel urgency than placebo. For ulcerative colitis, there was a more rapid improvement in stool frequency and rectal bleeding as early as week 3. Again, promising outcomes at week 12 and week 52 as highlighted in the data here. And we now have long-term data on this showing prolonged efficacy in terms of clinical remission, maintaining bowel urgency improvement, maintaining steroid-free remission, and maintaining this histologic endoscopic mucosal improvement, which was something seen in the ulcerative colitis maintenance study with this medication. Safety profile, you will see very similar to Tremfya, Stelara, and Skyrizi. There were slightly more cases of abnormal liver enzymes with this drug in the Crohn's disease study, so liver enzymes should be monitored, but otherwise these risks are very similar to the other drugs that I just mentioned in this class. So now we have oral medication. So this is probably a game changer. Many people like the idea of taking a pill as opposed to an infusion versus an injection, or a pill or injection. So JAK inhibitors, these are oral medications and novel mechanism of action. Many of the cytokine mediators of inflammation, like the TNFs, the IL-23s, rely on the JAK kinase pathway. So by blocking it, is a very potent anti-inflammatory pathway. So there's 2 of these medications that are used in IBD. There's tofacitinib or Xeljanz, which is only approved for ulcerative colitis, and there's upadacitinib or Rinvoq, which is approved both for ulcerative colitis and Crohn's. They are the main benefits of both of these medications. They can be used both for inducing and maintaining remission. I would say these are some of the fastest acting drugs we have out there. Within a couple of days, patients, sometimes even within a day, patients will tell me their bleeding, for example, has resolved or their pain has resolved. So almost as quick, if not quicker, than steroids. They have, like most of these medications, the potential to heal the bowel. They have steroid-sparing properties, and they can be used for patients that have been on TNF drugs, as well as those that have not been on it before. It doesn't seem to affect the outcome. Xeljanz was initially approved in 2012 for rheumatoid arthritis. It then got approval for ulcerative colitis in 2008. Crohn's disease studies did not pan out, so it is not approved for Crohn's disease. This medication specifically has an indication in the United States only for moderate to severe ulcerative colitis, and I underlined here, who have had an inadequate response or were intolerant to TNF blockers. And I'll get to that on the next slide. Xeljanz should probably not be used in combination with other biologics or immune suppressants. The induction dosing of Xeljanz is either a 10 milligram tablet twice daily or an extended release tablet of 22 milligrams once daily for 8 weeks. Can be extended up to 16 weeks. If there's no response by 16 weeks, the medicine should be discontinued. The maintenance dose is 5 milligrams twice daily or extended release 11 milligrams once daily. If necessary, the dose can be increased to 10 milligrams twice daily or 22 milligrams daily for maintenance. I would say that latter statement is the most effective dose for a majority of IBD patients. It's rare for me to have someone on 5 milligrams twice daily. Efficacy, there are a couple of induction studies that clearly show that this medicine is more effective than placebo, both in clinical remission and endoscopic improvement, and this extended out to week 52 at both the 10 milligram twice daily dose and the 5 milligram twice daily dose compared to placebo. So safety, this is generally for JAK inhibitors. There are infection risks with these medications, in particular in patients taking additional immune suppressants like methotrexate and steroids. All infections need to be treated. They should not start these medications if you have an active infection, and they should be paused if you have an active infection until the treatment for the infection is completed. You should notify your doctor or healthcare provider if you come down with any infection. Tuberculosis, like most of these medications, can get reactivated and or occur, so it needs to be monitored. Invasive fungal infections can occur. Bacterial and certain viral infections like shingles can also occur, which is why it's important if someone's going to be starting a JAK inhibitor, they should receive the non-live shingles vaccine called Shingrix, so they should at least start that vaccine when they're about to start this medication. So the reason this medication has some concerns is it has a black box warning. The first indication for this drug was rheumatoid arthritis, and rheumatoid arthritis patients also use anti-TNF drugs like Humira, Remicade. So when they were studying this drug in that patient population, they discovered specifically in patients 50 and above with any cardiovascular risk factor, including smoking history, they were noticing higher rates of all-cause mortality, meaning any cause of death, including sudden cardiovascular deaths compared to the TNF blockers. They were seeing higher rates of major adverse cardiovascular events, strokes and heart attacks, and higher rates of thrombotic problems like pulmonary embolism and deep vein thrombosis. So that's where that black box warning was generated. Interestingly, when this drug was later approved for ulcerative colitis, there is data showing that in ulcerative colitis patients, there is a baseline risk of these complications. But in patients specifically getting Xeljanz, there did not seem to be any increased risk. So there must be some component to this for either being over 50 or having rheumatoid arthritis that may predispose patients to some of these complications. But all JAK inhibitors, including Rinvoq, now has this black box warning because of data that was derived specifically from tofacitinib. In terms of malignancy, there are some concerns, non-melanoma skin cancers, lymphomas, and in smokers over 50, there may be increased risks of lung cancer. There's been some cases of bowel perforation, like diverticulitis complication, a peptic ulcer, and these are often occurring in patients who are also taking other medications like non-steroidal anti-inflammatory drugs like ibuprofen, Aleve, and or steroids. So this is more likely seen in a arthritis patient taking these medications. Everybody should have at baseline before they start the medicine a blood count, liver enzymes, and a cholesterol panel. During the induction phase, the CBC and liver enzymes should be checked every few weeks. And then on maintenance, the labs should be checked at least 3 to 4 times a year, so every 3 to 4 months. And a repeat cholesterol should be checked about 12 weeks into treatment because it can artificially elevate your cholesterol. Generally does not require treatment unless you have risk factors for heart disease and high cholesterol. Again, live vaccines should be avoided. The data right now show that this medication should not be used in pregnancy or if you're breastfeeding. Common side effects are nasopharyngitis, increased cholesterol, headaches, upper respiratory infections, muscle enzyme abnormalities, rash. There's something called JACNE, which is acne that develops on the face. This is more of a concern for younger patients. Diarrhea, and again, shingles. Rinvoq has approval for ulcerative colitis and Crohn's. Again, same indication, except it's also approved for Crohn's, although I think today they just had a new indication where you don't need to have failed an anti-TNF to be started on this medication. Up until today, you had to have had tried, at least in the United States, a TNF drug first before you can be eligible for a JAK inhibitor like Rinvoq. Again, not recommended for use with other immune suppressing drugs. The induction dose for this drug is a 45 milligram tablet for 8 weeks for ulcerative colitis and 12 weeks for Crohn's. And then there's two maintenance doses, a 15 or 30 milligram dose. Again, response is very quick, usually when it works, within a couple of days. Clinical remission, also pretty quick by week 8 when it works. I think most of these are similar to the other medications. Safety is pretty much the same, but again, you see this concerns here about mortality, thrombosis, and MACE. This, I would have to point out, has not been seen with Rinvoq in IBD patients. This is derived from the other JAK inhibitor that I discussed, tofacitinib, but because it's a similar mechanism of action, it's on the product label. GI perforation has been seen in a few Crohn's patients that have a narrowing in the ileal area, which one can argue that may happen in some patients with Crohn's anyway, but there were some cases in clinical trials where they saw some GI perforations with Rinvoq as well. And the same lab tests, CBC, liver enzymes, and lipid profile should be checked on this medication both during induction and maintenance. Again, this drug as of now is not believed to be safe for pregnancy or for breastfeeding, so we do ask that our female patients that are using this medication follow contraception and for 4 weeks after their final dose and not to breastfeed. Live vaccines, again, should be avoided, and the Shingrix vaccine is highly recommended when you're starting this medication. Lastly, I'll talk about S1P inhibitors. This is another oral medication, another novel mechanism of action. There's two of them on the market, ozanimod and etrasimod, Zeposia and Velsipity. Zeposia was approved in 2021. It's only indicated for MS and moderate to severe ulcerative colitis. So this is not used for Crohn's. And again, it's an oral medication. It comes in a starter pack that looks like this, where you titrate the dose up gradually over 7 days. The benefits, it works quickly as early as week 10. Patients had increased clinical response with this compared to placebo and clinical remission, and durable response up to week 52. Symptoms of bleeding and stool frequency improved as early as week 2. There was evidence of endoscopic and histologic improvement with this medication. And like most of the other medications, when it works, it can allow someone to become steroid-free and can work both in TNF naive and exposed patients, as well as patients that were previously on Entyvio. Contraindications, I think this is the main reason that these types of drugs have not really caught on, but anyone that has severe untreated sleep apnea should not take this medication. Anyone taking a different type of medicine called a monoamine oxidase inhibitor should not take this medicine. Anyone within the past 6 months that's had a heart attack, unstable angina, stroke or mini stroke, heart failure that required a hospitalization or advanced baseline heart failure, or any kind of heart block, unless they have a functioning pacemaker, should not be taking Zeposia. There are risks of infections like there are with other medications, but in addition, they did see some cases of the PML infection that I talked about earlier, and some severe cases of herpes zoster. So varicella immunity should be confirmed prior to starting treatment, and our patient should get the vaccine for at least a month before starting therapy. There have been some cases of a fungal infection called cryptococcal meningitis and disseminated cryptococcal infections. Blood tests, again, need to be monitored, CBC and liver enzymes. And the one thing I would point out here is this medicine works at the lymph node level, and it can linger in the body for up to 3 months. So you may remain immune suppressed for 3 months even after stopping the medicine, either for pregnancy or if you're planning on getting a vaccine, you're still at risk of infection. As I mentioned earlier, the medicine is titrated up because it can be associated with slowing down the heart rate. So it's titrated upwards. And if someone is on a calcium channel blocker or beta blocker or has any history of heart block or slow heart rhythm, you probably should get a cardiologist input. And all patients are required to get a baseline electrocardiogram. It may raise your blood pressure by a few points. It may decrease lung function in some patients. It can cause something called macular edema. So all patients should get an eye exam at some point, either before or shortly after starting treatment. It's been associated with posterior reversible encephalopathy syndrome, which is something I mentioned earlier that happened in one patient with Stelara. Abnormal liver enzymes and liver injury have occurred with this drug. Again, none of these side effects are common. I don't want to make it sound like these are very common side effects, but these are just things to monitor for. This drug is not considered safe during pregnancy. There's some rates of skin cancer with this drug, and the most common side effects with these drugs are, again, upper respiratory infections, abnormal liver enzymes, and headaches. Velsipity or etrasimod is newer. It was approved in October 2023. Again, only approved for moderate to severe ulcerative colitis, not Crohn's. And this is a once daily pill that does not require any titration. There were several induction studies showing efficacy, higher rates compared to placebo when it came to things like clinical improvement and endoscopic healing. And this extended out to week 52. Patients that were naive to other advanced therapies were more likely to respond to this than placebo, but it can be considered a first-line therapy, so you don't have to try a TNF or any other drug first. This was the first advanced therapy that looked specifically at some patients with proctitis. Many clinical trials specifically exclude patients that have ulcerative colitis limited to the distal 10 centimeters of the colon. So anecdotally, many of these medications that I've talked about do work, but sometimes they don't. And so this was specifically looked at as an endpoint. They allowed some patients with isolated proctitis to enter clinical trial and did find that those patients did benefit from this compared to placebo. Safety, again, very similar to Zeposia in terms of the past 6 months. If you've had any of these cardiovascular issues or heart block, unless you have a functioning pacemaker, similar infection rates. It doesn't last as long in the body as Zeposia, so it's about 4 to 5 weeks when your immune system returns back to normal. It can also, again, cause abnormal liver enzymes, blood pressure elevation, skin cancer risks, this PRES neurologic syndrome, decrease in pulmonary function, and again, is not considered safe in pregnancy. Most common side effects, very similar to Zeposia. Before starting either of these S1P inhibitors, all patients should get baseline CBC and liver enzymes, an EKG, varicella titers, and complete any live vaccines that they may need 4 weeks before. Or for Velsipity, 5 weeks after they can get a live vaccine, or 3 months after for Zeposia. Many of these drugs are used in combination. I can answer these more in the Q&A. And so how do I choose medications? It all comes down to case-by-case discussion with patients. We have PO medications, we have IV, we have subcutaneous options. So route of administration plays a role in deciding sometimes how compliant patients are going to be with medications. Definitely plays a role. As I mentioned, some of these medications require careful monitoring of lab work and certain vaccines. And if patients are not consistent with regular follow-up for lab work or office visits, it may not be safe to take a medication that requires careful monitoring, whereas some of the other medicines don't require as aggressive monitoring. Safety concerns, monitoring, I mentioned pregnancy and or breastfeeding if someone's planning on having a child. As you know, most patients with IBD are of childbearing age or usually presents at that age group. That's a question I'll ask patients. Are they planning on getting pregnant or what their pregnancy plans are? And that may play a role into which of the medications we're going to use. As I mentioned earlier, only the oral medications, the S1Ps and JAK inhibitors should not be used in pregnancy. Everything else, and also methotrexate should not be used, but all the others are considered safe in pregnancy. We'll look into patients' existing medical history. For example, if they have advanced heart disease, cancer history, if they also have other autoimmune diseases like plaque psoriasis or psoriasis or psoriatic arthritis, we may be able to use one of the drugs that may be effective for both indications. So these are things that we look at. And we also look at IBD medication history. So if someone's already been on an anti-TNF and had an adverse event or didn't work, probably doesn't make sense to use another anti-TNF. Same with each of the other medication categories. Someone has a history of recurrent infections, that way will weigh into what medicine we choose. And ultimately, and I don't need to tell all of you this, the cost of the medications and or the insurance company is usually the rate limiting step here. I just want to end with this slide here, which is pretty much my day at 4:30 after I see patients in the office. It says here, laughter is the best medicine, but your insurance only covers chuckles, snickers, and giggles. So if you know what I'm talking about here. So I think that was the last slide.
Thank you very much, Dr. Balani. We will take some questions now. Is there any non-surgical treatment improvement with strictures in Crohn's? How do you know when surgery is
I see.
needed?
Yes. Okay. So yeah, so many patients with Crohn's do have an advanced form where the bowel wall starts to narrow down. And so if there is what we call an inflammatory stricture, meaning there's edema and swelling in the area, which usually can be detected, for example, with the inflammation markers like a CRP calprotectin or some type of cross-sectional imaging like a CAT scan or intestinal ultrasound or even a colonoscopy. If we see a very active mucosal inflammation and that's leading to a narrowing or stricture, then that, if we find the right medication, can generally either stop the stricture from getting worse or even potentially reverse it if it's all an inflammatory stricture. However, if there's been advanced inflammation for extended period of time, just like if there's inflammation anywhere in your body, eventually scar tissue starts to get laid down. And so when scar tissue develops, none of these medicines really can work in that setting. And so the role of medications there is in most patients to delay the inevitable. So if there's a stricture there, but we found the right medication, and now there's no active inflammation, but from the years of narrowing the bowel wall, structural damage has already occurred. Our hope is with the medication that we maintain that patient in remission so that they don't have an acute flare. And when you get a flare, you get edema, you get swelling, you get ulcers, and that little narrowing of the bowel wall can completely close up, and that may require, will cause a bowel obstruction. It may require hospitalization and or a complication like an abscess or fistula may develop, and then patients may need surgery. So the key is basically to see if there's signs of inflammation. Every medicine that we've talked about today, they're all in one way or another an anti-inflammatory. So if we see active inflammation, we can potentially prevent or delay the need for surgery. But if there's scar tissue or narrowing from years of inflammation, medicine's not working, delays in treatment, or just an aggressive form of the disease, then most of the time there's surgical approaches to that. So hopefully that answered the question.
Dr. Balani, I've heard some institutions who have patients with severe refractory Crohn's who have failed remission with monotherapy with all the medications you have mentioned have seen significant endoscopic and clinical improvement, including achieve remission with dual therapy using Rinvoq and Skyrizi at the same time. Any experience or thoughts regarding combination therapy with
Mhm.
Rinvoq and Skyrizi?
So yeah, so that is an interesting question. So as I mentioned, with most of these medications, they have several indications, with the exception of a few of the medications. So many patients have concomitant Crohn's and say psoriasis or psoriatic arthritis or rheumatoid arthritis. So we'll often work in conjunction with a dermatologist or an immunologist or a rheumatologist where we'll treat one disease with either Skyrizi or Rinvoq, and they will treat the other disease with the other medication. So the reason that usually has to be done is the US healthcare system. It's very difficult for us to get approval from the insurance company for two of these types of medications because they're super expensive for one indication. I think the other part that's missing here is we don't have, as of yet, although this is in process, clinical trials using a combination of several of these medications to see if they're more effective than either one alone. Those trials are ongoing. So some more data will come out. I think anecdotally, we do see some patients that benefit from combination treatments. As I mentioned on one of the slides, we've been using combination treatments for years in IBD. It's not uncommon for patients to be on a steroid and TNF blocker or IL-23 when they're flaring. We've often used Pentasa or mesalamine with steroids. We've used the immune modulators with anti-TNF drugs. Very commonly, Entyvio being a gut-specific medication, we'll use that in combination with something like Skyrizi or Rinvoq or IL-23 because they have other indications. In terms of outcomes, I would assume some patients would fare better with using the combination. In a community hospital, it's difficult to get both together approved. In an academic setting, it might be easier to get because there's a lot of clinical trials are running. But there are a handful of patients who have just severe Crohn's disease where clearly they got better with, for example, with these two medicines that were mentioned, Rinvoq, but they're still flaring. So there are some patients that I would like to add Skyrizi or some other medication. It does take a little bit of a while, battle with the insurance company, appeal letters, especially when it comes down to this is it, or the patient winds up needing surgery or it's impacting their quality of life. So it may require some extra uh, marathon running with the insurance company to get approval. But I think over time, we just need more head-to-head and studies showing that the combination of dual therapies would be effective for one indication, and we'll be able to do that more regularly.
Several other for moderate to mild Crohn's patients that are currently being treated with biologics, specifically Skyrizi, is it possible to stop the medication at some point after achieving an extended period of remission? Do patients generally have to take these drugs for life? What are the risks specifically to the liver or of long-term use of Skyrizi?
Okay. So the first part of the question, I think, was how long you have to be on the medication or if you can stop it. Is
You
that
can
correct?
stop it if you've been in have you if you've been in remission for a while.
Okay. So I'll preface that by saying we don't have that data yet. We have, this is a relatively new drug. I mean, it's been studied for several years and now it's been on the market for a few years. And most patients that when they respond to that, they have prolonged response to it. They continue to do well. And the side effect profile really doesn't increase over time. So the baseline risks are very similar to what we talk about. We are not yet at that level where we can comfortably say we can withdraw medications. It's been our experience with every other medicine that's been around for years that when patients, and going back to even the basic medicines like mesalamine, and I'm sure many patients have seen this with steroids, as soon as you withdraw the medication, at some point the disease comes back, and that all goes to the problem that we just don't know what causes these diseases. There's no yet cure. Your immune system is still there. At some point, when the medicine is no longer in your system, the inflammation starts to build up. It'll be subclinical at first with some fatigue, achy joints, just general mild symptoms until you get full-blown ulcers, and then you start having all the major symptoms that led to seek medical attention in the first place. So our assumption is with drugs like Skyrizi, when you stop taking the medicine and it's no longer in your system to maintain your immune system from overreacting to whatever it's reacting to, then you're going to flare again. I would say one positive with the newer drugs, they're less immunogenic. So, with Remicade and Humira, those types of medications, the anti-TNFs, if there's a long gap in treatment for whatever reason, many people will develop antibodies. And then if they wanted to restart it because it worked really well years ago, we generally can't because they've usually developed antibodies. That does not seem to be that significant of an issue with the IL-23s. So as of now, I would say it is a lifelong treatment, with the asterisk being it's a lifelong condition. So if the better medication comes along, a safer medication comes along, hopefully a cure comes along, you don't necessarily would have to be on something like Skyrizi long term.
For
And
the
then the
patient,
second part. Uh-huh.
oh yeah, I'm sorry. Do we have something to mention? If you take them for life, what are the risks of long-term use?
So the risk to long-term use from now, again, is accumulating data across 4 indications specifically for Skyrizi, because I think that was the question asked. There does not seem to be any increased risk beyond what I discussed about. I have not seen anybody with significant liver disease with the medication. Usually, if someone already has an advanced liver disease like cirrhosis, the medicine should not be used. But if someone at baseline does not have any liver disease, I just monitor the liver enzymes during the IV induction dosing. And then once they're on the maintenance dose, usually that liver enzyme is checked as part of your annual physical and your metabolic panel. If your primary care doctor has not done it, your GI provider or a Skyrizi provider should be checking it. And we have not seen any significant liver signals or concerns. The other added promise to that is the liver specialist. When we do have, transplant patients that happen to have Crohn's disease or ulcerative colitis, and they need therapies like this, they will often they have the data on, liver issues, and they'll let us know the class of medication if it's contraindicated. And I would say that none of the IL-23s that they've told us in the past have been contraindicated in the setting of that issue. So I don't think there's any significant long-term liver issues that we've seen. And most of that data is also extrapolated from Stelara. Stelara has been around since 2009 and really is not associated with significant liver issues 16 years out. So,
For the patient who experienced
Mhm.
drug-induced hepatitis from Skyrizi, how long was this patient on the drug before his or her liver enzyme spiked? There is increasing feedback
Mhm.
from patients that Skyrizi is showing significant negative impact on liver function.
So that's an excellent question. So in the clinical trial, again, it only happened in the Crohn's disease trial. It did not happen in any trials for psoriasis, psoriatic arthritis, or even ulcerative colitis. And it happened during the IV induction phase. So I don't remember if it was the first or second infusion of Skyrizi, but shortly after one of those three infusions, they broke out in a rash. Had liver enzymes were checked as part of the workup, and the liver enzymes were very, very high. They held the drug in the clinical trial. They ruled out all other causes of, hepatitis, and everything came back negative. And the final conclusion was the drug-induced hepatitis. They gave that patient steroids for the rash and in the autoimmune, the drug-induced hepatitis, and everything came back to normal. The liver enzymes, the rash, and the patient did not have any long-term sequelae of liver disease. So that's really the only data that we have on that.
How frequently do you allow insurance companies to dictate treatments for your patients?
Well, until the US healthcare system changes, unfortunately, because of the cost of these medications, I will usually sit down with patients, especially if they're newly diagnosed, and go over every one of these medications. I'll have some sense as to which medicine I would prefer the patient be on based on their medical history, comorbidities, and other factors that I mentioned earlier. And then we'll usually make a mutual decision about which of the drug that we want to pick. And that's the one that we will do the a request for the insurance company or prior authorization. Almost all of these drugs are indicated as first line. So there really is no reason why they should not be used first line if we chose to pick that drug, with the exception being the JAK inhibitors until today with the new indication. However, we often get denial letters from insurance companies, which is very frustrating that they want you to try something else, either another anti-TNF or steroid or an immune modulator or Pentasa or some other mesalamine drug. And majority of the time, if it's a silly reason, it's just a matter of doing an appeal letter, or doing a peer-to-peer and fighting for the patient's cause to justify why we think this medicine is chosen and that the insurance company should not interfere with patient care decisions, and it would be detrimental to their health if we chose something else because we've already had that conversation. And if someone really doesn't want to take a Remicade, for example, because they have a strong family history of melanoma, that's just a scenario that happened recently with one of my patients. But the insurance company, that was the only drug they would approve. Well, I would, fight with the insurance company, and we did win that appeal. So it's a struggle. I am not going to lie, but usually we win this out. The other part of the dictation is we also have to be realistic at times. The good thing at 2025 is we now have so many options. So if we pick a newer drug, whatever it may be, and the insurance company says no, or the cost is prohibitive, but they will approve one of the other advanced therapies. I've been using pretty much every advanced therapy. I think they're all very good. Each has risks and benefits. And so that's why I do discuss the risks and benefits of each and every medication with the patient. So if it comes down to, okay, your insurance company is not going to approve, or your out-of-pocket cost is going to be thousands of dollars for this drug, but they will cover this other drug that may be just as effective, then we will have to, give that drug a try. So it is a struggle, and that's a very good question. But I'm pretty sure if you have Crohn's or ulcerative colitis or have family members or take care of patients, you know what I'm talking about. So.
What are your thoughts on Stelara and azathioprine with
Mhm.
prednisone therapy? I have severe Crohn's.
So I guess the question is if you're on all three.
Yes, it sounds like that.
So, I mean, in reality, that's probably happening quite a bit. Um, in practical purposes, it's probably not necessary. I mean, technically, for example, with Stelara, the product label generally does not require you to be on azathioprine, which is another immune suppressant. However, there are a fair number of patients that are on both of these medications for different disease states. So, I mean, it's not unheard of. I would probably in that situation maximize the Stelara dose or frequency and use the lowest effective dose of azathioprine, but it is a double hit on the immune system. So you do have to be up to date with age-appropriate non-live vaccines and follow precautions for any infections and any signs of an infection. These medicines would need to be held and the infection treated appropriately. Prednisone above 20 milligrams, I would say, is very immune suppressing, probably way more immune suppressing than any of these drugs that I discussed. And that's something that many patients and people don't realize how significant prednisone above 20 milligrams can suppress one's immune system. And all the rates of infections that we've talked about with all of these other medications are pretty high with high doses of prednisone as well. So if you can keep the prednisone for the shortest amount of time, preferably at a dose less than 20 milligrams, that would be suggested. Budesonide would be a safer steroid to use in that situation if you need a steroid for a little bit longer than prednisone.
That's the last question that I see. I want to thank Dr. Balani for spending so much time tonight with us. And like I said, I will stay around for so that you can complete the survey tonight. Thank you very much.
All right, thank you, everybody.
Thank you, Dr. Balani.